so thrilled. Thank you for recording the session. So we are so thrilled to have you with us today, and thank you for tuning in from near or far. We are excited for what's ahead and grateful to share this session with all of you. And also, as you know, this webinar will be recorded and it will later on be uploaded on the YouTube channel of the Ministry of the Public Health, so that way you will have access to it later on. And I want to ask everyone if you have filled out the attendance sheet. And if not, you can do it now because the link is available in the chat box as well. So later on, you'll receive your certificate of participation. And I will first start by introducing myself. So I am Cristel El-Ashar, and I will be the moderator for this session. And I am an incoming Med 1 student at the American University of Beirut. And I'm very excited to be a moderator for this session, as I will have the opportunity to introduce truly inspiring people. And also, I would like to ask you if you can proceed by putting your name, introduce yourself in the chat box so we can get to know more about your background, your city, your country, your studies, what you are doing, and get to know more each other. And while you are putting all of your information in the chat box, I would like to give a quick but a heartfelt thank you to Mariz Aboud and Nuhat Haidar, the amazing duo working behind the scenes to keep everything running smoothly. And we extend our thanks from the panelists and I and all the participants for all your hard work. Now, moving on to the webinar's aim, today our webinar is going to explore the evolution of cancer treatment from conventional chemotherapy to advanced therapies, such as targeted therapy and immunotherapy, while reflecting on local and international context. And let me just review with you rapidly and briefly the agenda. We will be talking about expanding indications for multimodal therapy in the area of immunotherapy for patients with advanced foregut malignancy with Dr. Sherbel Sandrousi. And we are also going to delve into the updates on cancer therapy with perspectives on Lebanon's context with Dr. Arafat Tfaili. Now, here is what we need to know about the housekeeping rules. First, the microphones will be muted for all attendees throughout the session to ensure a smooth experience. Questions should be shared in the Q&A box or left for the Q&A session. During the Q&A, questions from the Q&A box will be selected and asked to the speakers, and attendees will be allowed to unmute their microphones for further interaction at that time. Attendees are kindly invited to remain respectful, stay on topic, and minimize disruptions to the session. And finally, participants who attend the entire session on Zoom will receive a certificate. Now, before we start, I would like to ask you to take a moment to fill the first poll survey that will appear now in front of you. So the question is, how familiar are you with precision chemotherapy? Never heard of it but don't know much about it, know a little bit about it and very familiar with it. So we will give you 1 minute so you can respond to the question. Okay, so here we have the results in front of us, and the majority is saying that they heard about it, but they don't know much. So that's why we are now going to start with our first session, and it will be with Dr. Sandrousi, and I have the pleasure to introduce Dr. Sandrousi. So Dr. Sherbet Sandrusi is a hepatobiliary upper gastrointestinal and transplant surgeon in New South Wales, Australia. Performing over 200 major cancer resections annually, he is among the highest volume cancer surgeons in the area. He earned his medical degree from the University of Sydney, completed advanced surgical training in Australia and Canada, and earned accreditations from the American Society of Transplant Surgeons and the American Hepatopancreaticobiliary Association. Dr. Sandrusi currently serves as head of the Hepatobiliary and Upper Gastrointestinal Surgery Department at Royal Prince Alfred Hospital and as associate professor at the University of Sydney. He also leads research at the RPA Institute of Academic Surgery and the Surgical Outcomes Research Center. His work focuses on complex oncological surgery, transplant outcomes, and improving surgical care for frail patients. With that, Dr. Sandrusi, the floor is yours, and I'm going to stop sharing my screen so you can share yours.
Thank you. I'll just try and share my screen. Does that look right? My name's Charbel Sandrusi. I'm an upper gastrointestinal and hepatobiliary surgeon. I also do transplantation surgery. I'm from Sydney, Australia. I'm grateful to be asked to come and talk at this session. I look after lots of patients with complex oncology and get referred patients, particularly with cholangiocarcinoma and advanced esophageal cancer from around Australia with locally advanced and occasionally metastatic disease for management. I'm not really an expert on chemotherapy. I'm a surgeon, but I am a surgeon who looks after lots of oncological patients, and we are heavily involved in the oncological care of the patients. And so I think I'm in a reasonably good position to talk about this type of
Just Dr.
treatment.
Sandrusi, we are sorry to interrupt you, but we can't see your screen.
Okay, let me start sharing. I'll try a different sharing mode. Is that better? Can you see the screen now?
Yes.
Yes. Yes, now we can.
Sorry about that. And I apologize for wearing normal clothes. It's 2 o'clock in the morning in Australia. So I haven't had much sleep yesterday or today because I've been working. We all understand about how cancer grows. Historically, we've thought that cancer was the acquisition of stepwise acquisition of genetic mutations, which led to uncontrolled proliferation of abnormal cells, and then that causes damage to the organ that the cancer arises in, and then subsequently causes spread to other organs and damage to the host and death. We now know, after doing lots of analysis of the genetics of cancer, the cellular proteins and the microenvironments of cancers, that it's much more complicated than that. And actually, that's been helpful because the increased understanding of the complexity of cancer formation and cancer growth and disordered cellular growth has created extra targets for treatment. And that's really, and also for diagnosis and for surveillance and screening. And that's really where precision medicine and precision chemotherapy and cancer care comes in. You basically look at all the different pathways from the early stages of cellular damage, and then as you go along with acquisition of increasing genetic damage in the cell, and you look for targets where you can interfere with the cellular damage and reverse the process of malignant transformation, or take the process of malignant transformation back to being normal cellular growth. And they've had variable levels of success, and there's increasing work being done in all the different tumor groups in these areas. Cancer remains a huge burden globally. There's about 10 million people who die each year. In Australia, it's the second most common cause of death, and probably similarly in Lebanon, the increasing rates of cancer. And the actors, the bad actors are still the same. It's lung cancer, colon cancer, breast cancer, and pancreas cancer, which kill the majority of people. And we still haven't made a significant impact, particularly in Western countries, on the frequency of cancer. And in some aspects, a lot of certain cancers, particularly foregone malignancies, have increased. We've seen a tenfold increase in the rate of pancreas and cholangiocarcinoma in our community, and an increased incidence of esophageal cancer, which is probably related to exposure over a long period of time to heavily processed and refined foods and all the preservatives that go into the food that we eat. There are some cancers where targeted treatments have been highly successful, and also where tailored treatments and also tailored surveillance programs and intervention prior to development of cancer have been highly successful and are in mainstream use. And probably the archetype of that is breast cancer and melanoma. In breast cancer, patients get next generation sequencing of their tumors right at the outset, and then their treatment paradigm is determined by what the genetic analysis and the hormone receptor status of their tumor is. And patients are having less and less invasive surgeries, more and more conservative and breast conservation and function preserving surgery, and having better survival as well. They're also having pre and post-operative systemic treatment for much longer periods of time, and that has also led to better outcomes. And in melanoma, the use of immunotherapy and other targeted treatments has basically changed the paradigm of how melanoma is treated, particularly metastatic melanoma, and also the survivals. There are many other examples in the different cancer streams where particular protein levels, cell surface receptors, or genetic changes have led to particular treatments having a particular effectiveness in stage 3 and 4 cancers, such as in lung cancer, where EGFR receptor inhibitors can turn what was once incurable stage 3 and 4 cancers into curable diseases. And there's increasing use of pembrolizumab in patients with MSI high colorectal cancers, which lead to sustained and durable responses to patients even with advanced disease. One of the ways that precision medicine is going to become more and more used is in the identification and analysis of patient risk, and then risk stratification, and then either surveillance or intervention to mitigate the risk. We know there are lots of things in a person's life and also in their genetics which increase their risk of cancer. And as time goes by and we acquire more and more data on patients who have cancer, we're going to be able to work out a risk profile for a particular individual. We're going to be able to look at their UV exposure throughout their lives, their exposure to other radiation or other tumorigenic factors. We're going to be able to do relatively straightforward genetic analysis to identify whether they're at a particular risk of certain tumors, and then look for the circulating tumor cells and proteins in their blood, and then tailor surveillance and or investigation and intervention for them before they get cancer, or at a very early stage identify the cancers and treat them when they're much more curable. So what is personalized medicine when it comes to cancer? So basically it's trying to identify the patient and the characteristics of the patient that lead them to have a higher risk of a particular disease. And once they have the particular disease, or they have the risk for that particular disease, to analyze the disease and work out whether there is a particular target for any sort of treatment that will increase the effectiveness of the treatment, and also to reduce the toxicity of the treatment. In general, patients who have cancers get standard doses of medications based upon their body surface area. And with personalized medicine, I think we're going to ultimately be able to tailor treatment doses and treatment types to particular patients' genetics, and also the patient's underlying biology, so their ability to metabolize the types of cancer agents, chemotherapy, the immunotherapy, and also work out what agents are going to be more effective from the point of view of how the patient's body metabolizes them. After they've had their treatment, personalized medicine is also going to be useful for surveillance, identification of early recurrence, and this is already in place with liquid biopsies, identification of circulating tumor cells, looking at circulating tumor cell density, and treating patients on the basis of the presence of circulating tumor cells. And we've done recent analysis and treated patients with high levels of circulating tumor cells following pancreatic cancer treatment, where we've been able to identify the patients at risk and having recurrence at a much earlier stage and start treatment for their recurrent disease when it's much smaller, leading to improved survival. And at the moment, we don't know whether the survival improvement is as a consequence of lead time bias, but that's something that will work out over the next several years. In theory, you'd think that treating a tumor when it's much smaller has better effectiveness, but we don't know whether the reason that they survive longer is just because we find the tumors earlier, rather than us interfering at a point where we have a better effectiveness for control. So what do we do when we see patients? So the management of these people is multimodal, and it's also multidisciplinary. So we start with the basic things. We take comprehensive history, particularly we look at their family history and their genetic history. We look at their risk factors for certain tumors, and then we do molecular testing, either molecular testing of the patient. So some people have genetic testing looking for certain germline mutations or somatic mutations which increase their risk of cancer. There are some diseases where you make the diagnosis on the basis of physical characteristics, such as patients with neurofibromatosis or familial atypical melanoma mole syndrome. And then we then do, if they get cancers, we then do genetic analysis of their cancers. We do a lot of data collection. So patients who have certain types of cancers, we biobank their tumors, and then we do genetic analysis both historically and prospectively of the patients and of the population to work out about treatment. And then we try and tailor treatment and define trials that are going to target the particular molecular profiles and genetic profiles of the tumors in our population and the tumors in our patients. We're also using precision medicine to tailor and adjust treatment doses. Most patients now get DYPD testing so that we can work out that they're not going to get toxicity from certain chemotherapy agents. And also we try and find out whether they've got specific mutational troubles which may alter their ability to metabolize certain drugs and reduce their effectiveness or increase their toxicity. We all know that tumors are not just one type of cell, and there are lots of different treatments that target particular tumors, and there are lots of tumor paradigms where you get one, maybe you have a metastatic tumor, but the cell types are heterogeneous. For metastatic melanoma, for instance, stage 4 melanoma in general is treated with immunotherapy such as ipilimumab and nivolumab. And in about 30 to 40% of people, that leads to a very durable long-term cure for those patients. And then there are occasional patients where resistant clones occur. And that's a consequence of the tumor cells being heterogeneous. And in those patients where they have resistant clones, they often get surgery. And in our cohort, for those types of tumors and others, we biobank all of those tumors and we do next generation sequencing and genetic analysis. That helps us work out whether there are other targets of treatment that we can give them, or whether they are suitable to go into one of the adjuvant trials. Certain tumors have different microenvironments which make chemotherapy more difficult and the treatment more difficult, and also some surgery more difficult. One of the typical ones of those is pancreas cancer, where there's a significant fibrotic element to the tumor. There have been drugs developed which help target the fibrosis, such as nab-paclitaxel, and they improve the effectiveness of the chemotherapy treatment. We have had recent trials where we inject nanoparticles in induce fibrinolysis around the tumor and try and improve access and drug delivery. Those trials are in phase 1 and phase 2 areas right now, and so we won't know the outcomes of those for a number of years. And what we want to do is we want to try and work out the best way to get the treatment to the patient with the least toxicity, and also when there's escape of tumor, how we manage that. Currently, when we find a patient who's got cancer, we have conventional methods of staging, and we haven't really moved forward to using the more complicated methods of staging, except really in patients with hematological malignancies, where the more complex analysis of the tumors does really inform the nature and duration of treatment. In most solid organ tumors, we still have our traditional testing with cross-sectional imaging, functional imaging with PET scan, and then there's the occasional patient where decisions are made on the basis of biomarker levels and other molecular profiling. But for the most part, initial treatment decisions in the treatment paradigm is formed with our traditional methods. These are fairly crude, and they don't really help us to work out which patients are going to do well or badly with our treatment that we offer them. And as time goes by, we're incorporating more and more next generation sequencing and genomic testing, much more somatic mutational testing. We're doing more liquid biopsies, and we're also doing other biomarker analysis to work out about what the right treatments for particular patients are. And we're trying to intervene and give people better treatment up front that's more suitable for their particular tumors. These types of treatments are a bit easier to administer when patients have unresectable tumors. So patients with locally advanced pancreas cancer, we always do whole genome testing of the pancreas cancer to work out whether they've got actionable mutations, which will afford them better results with chemotherapy. For patients who have resectable disease, in the absence of the need for neoadjuvant treatment, such as patients with liver cancer or pancreas cancer, it's very hard to convince the patients to go through large batteries of tests, which may stop them from having surgery. So we're not at a stage where we're doing this for everybody just yet. You might ask why we do this. I guess the main reason for doing precision medicine for cancer and also precision treatment for patients with cancer is to try and improve survival. And I think if you take the whole picture of cancer care and oncology, and if we apply the concepts of precision treatment to all the different parts of cancer care, we can substantially reduce mortality, morbidity from cancer, and we can also reduce toxicity of treatment. It's going to require like a population-based effort, and the other limiting thing is the funds. It's not really a cheap process because it does require implementation of certain things at a population level, certain screening and surveillance things at a population level, which are very, very expensive. And so, whilst the goal is very noble, the actual practical parts of getting this type of treatment into mainstream care are much more difficult. What have we done in the past? So in the past, surgery has been the mainstay of curative treatment for most solid organ tumors. And we used other treatments as an adjunct. We use hormonal therapy, radiotherapy, and chemotherapy as an adjunct to reduce survival or to improve resectability. To reduce mortality and improve resectability. And as time goes by, we're using more and more systemic therapies, both before and after surgical treatment, to improve the outcomes of both the surgery and the long-term outcomes of the patient. And that's happened in most solid organ tumors. So there are very few cancers now where surgery is done in the absence of any consideration of either adjuvant or neoadjuvant treatment. In addition to our standard treatments, most patients now get some form of tailored treatment. So if you look at patients who are having my sort of tumors, so patients with esophageal cancer, historically we've given them treatment with neoadjuvant chemoradiation, and then if they've got disease if they've got any residual disease after treatment, those patients have also received adjuvant immunotherapy. For patients with metastatic esophagogastric cancer, they now all receive nivolumab as well as the standard chemotherapy. And there are multiple trials going on in countries where people are now going to get doublet immunotherapy agents as well as chemotherapy agents for gastric cancer that's either locally advanced or metastatic. And there's a number of patients where we can convert them from being incurable to being curable with these specific immunotherapy and targeted agents. Other targeted treatments for upper GI malignancies, particularly gastric cancer, is Herceptin or trastuzumab. Certain tumors have a high density of HER2 receptors, and those patients all get adjuvant trastuzumab with their normal chemotherapy if they express that. There are both hematological and solid organ tumors which are exquisitely sensitive to imatinib. And then there are lots of other targeted agents. The other one that we use is in patients with BRCA2 mutations. We use the PARP inhibitors, olaparib, as a maintenance treatment after they've had their induction platinum treatments for their pancreas cancer, particularly in patients in the metastatic or locally advanced setting who aren't converted to being resectable after their initial chemotherapy. These are some other particular mutations which have led to specific drugs being used for targeted treatment. The common ones that we see now are HER2 in breast, gastric, and certain other cancers. More and more patients are getting targeted treatment with cholangiocarcinoma and bile duct malignancies. We do next generation sequencing on all of our patients who have cholangiocarcinoma and bile duct cancers. And if they've either got IDH1 mutations or FGFR mutations, they get targeted treatment. For patients who have melanoma, thyroid cancer, colorectal cancer, we tested for BRAF mutations and they get pembrolizumab. And then there are other specific genetic mutations that are expressed in the tumors, which allow us to target specific cancer therapies to those patients. And also, in some patients, have allowed us to avoid doing surgery because the responses to treatment are so good. These are some of the examples of the types of treatments. Really, the standout things for cure where there was none are the EGFR receptor inhibitors in patients with advanced lung cancer. In those patients, we had a mortality of 95% at 1 year, and now about a third of them survive long term with appropriate immunotherapy and EGFR receptor inhibition. The other aspect of personalized medicine as it pertains to delivering drugs is how to deliver the drugs with the best effectiveness and the least toxicity. And there are programs. We have programs in our institution looking at genetic profiling, assessing assessing the metabolism of patients, the cellular metabolism of patients, to work out what the optimum drug dosages are, what the optimum drug frequencies are, and how we can mitigate side effects from the various chemotherapy and immunotherapy agents. Historically, we've just used the patient's body mass, their body surface area, and then monitored for toxicities as they occur. We're trying to proactively interfere with the development of that by dose adjusting or avoiding certain medications which may cause toxicity in patients with particular metabolic problems. One of the special drugs that we have been using over the past 15 to 20 years is male inhibitors of TOR. mTOR inhibitors are mostly used in transplantation patients, both liver and kidney transplantation, as an immunosuppression. And their ability to kill tumor cells was found by accident. These drugs were used as to try and treat HCCs in mice xenograft models. And over the weekend, once they accidentally left the sirolimus running through the mice xenograft, and when they came back on the Monday, when the experiment had run for a few extra days, they found that the HCCs that were implanted in the peritoneal cavity of the mice had shrunk down. There are certain patients, particularly with renal cancer and some predisposing genetic mutations, where they have a great sensitivity to the mTOR inhibitors, and those patients get mTOR inhibitors as a routine if they get metastatic disease with their renal cancer. In upper GI surgery, we commonly use FGFR receptor inhibitors, particularly for bile duct cancers. This has been a real paradigm shift for patients with metastatic or locally advanced bile duct and gallbladder cancer, because we've been able to affect, not in a huge number of people, but in a good proportion of the patients who have these incurable cancers, they've been able to get very good and durable and sustained responses to these medications. There are a proportion of patients with FGFR receptor mutations where they can get complete cell death of the cancer and have long-term survival with even metastatic or locally advanced unresectable bile duct cancers. We've looked for these mutations in patients who have got advanced high cholangiocarcinoma that can't be treated with surgery, and we've tried to use these medications as induction treatment prior to considering these patients for liver transplantation in combination with our standard chemoradiation. These days, more and more of medicine and of society is using artificial intelligence. And I think artificial intelligence is going to be one of the key drivers to improvements in cancer outcomes. And it's going to drive improvements in all of the different aspects of cancer outcomes. So I think using large data sets and getting large amounts of information about the population base with cancer, we're going to be able to use it for screening, improvements in diagnosis, prognostication, and also to monitor patients. We've got a couple of high degree research students who are looking at the use of machine-based learning systems for diagnosing solid organ tumors in the liver and pancreas, and also assessing whether tumors in the pancreas particularly are resectable according to normal resectability criteria, matching that to the pathology, and then looking at testing the prognosis and being able to prognosticate on the basis of the preoperative imaging using large data sets and machine learning. It's already in place for diagnosis of certain tumors, contrast enhanced ultrasound, and there are automated AI programs for looking at and mammography and diagnosing breast cancer, and they're as accurate or more accurate than expert radiologists when they're used. We also use certain biomarkers to help us both define and diagnose tumors, as well as monitor treatment outcomes and also to predict prognosis. In upper GI surgery, the common biomarkers are CA19-9 and CA72-4. In other colorectal cancers, it's CEA. And the biomarkers are useful when they're present because they help us monitor the response to treatment. We are more and more moving towards using circulating tumor cells and liquid biopsies to identify the presence of cancer in the peripheral blood. We also are studying the density of the circulating tumor cells and how the density of those CTCs respond to the various neoadjuvant and adjuvant treatments to help us work out about prognosis. And as I said earlier, for pancreas cancer, we've done many studies looking at circulating tumor cell, pancreas cancer circulating tumor cells, as well as the tumor density. And it correlates very accurately with early recurrence of the cancer. So when patients' CTCs go up, even in the absence of anything on imaging, it's very predictive of a recurrent pancreas cancer. And on that basis, we've started treating patients. We've also used the peripheral blood circulating tumor cells to grow mice xenografts. And as the patients are recovering from their pancreas cancer, we've been testing their tumors and seeing whether their tumors respond to the chemotherapies we're planning to give them. So we've been using the CTCs and the biochemical markers to help us with treatment. There are some other adjuncts to personalized medicine, things like prehabilitation, nutrition, and then other forms of therapy. At most comprehensive cancer centers, including ours, patients get these other types of treatments, and they're useful, whether it's physiological or psychological. Patients seem to enjoy having acupuncture and reflexology and sports medicine and exercise physiology as they're going through their cancer care. And so there is a role for that in our precision-based care as well. This is an area which is emerging, so using nanotechnology in cancer medicine. And this will become more common and much more used specifically for taking drugs to particular tumors and allowing a much higher concentration of drugs to be delivered to and maintained in the tumors. We have some nanotechnology that we use for...
Just Dr. Sharbel.
Yes.
Yeah, sorry for interrupting you, but just to let you know that you have around 5 minutes left.
Yeah, I'll be finished in 5 minutes. That's fine.
Thanks.
We use nanotechnology for delivery of drugs and for delivery of certain treatments, and that's an emerging space, and you'll see more on this over the next 5 to 10 years. Some of the difficulties in implementing these types of treatments, and particularly in places where the medical community is a bit fractured, and also where the amount of money that the hospital systems have is not high, is the biggest thing is cost. And the other thing that we've faced difficulty with is privacy, because when you have patients' information in large data sets, it's very hard to keep all of the data completely private. And so most of the data sets that we use for analysis are all de-identified in a centralized database. And the patient information is separate to where we keep the data about the genetic analysis and the genetic parts of the tumor. If you look at the cost, the dark blue one is the traditional treatment approach. And you can see that it's cheaper at most areas, except when you look at complications. So if you look at personalized medicine, what we hope to get is to get the treatment a bit cheaper with time. But if you have the right treatment at the lowest dose, you end up reducing complications and reducing cancer, improving cancer outcomes. So ultimately, it will be less costly. And these things are not really easily accessible in low-income countries because of infrastructure and cost. And they're relatively well accessed in high-income countries. Like we have very good access to personalized cancer medicine in Australia. I'm just going to do a quick case. We've had many cases like this now since we started using immunotherapy for patients with advanced esophagogastric malignancies. This is a PET scan of a 42-year-old patient of mine who had a diagnosis of esophageal cancer in 2021. He had 3 months of dysphagia, and he had an endoscopy showing an adenocarcinoma of the distal esophagus. And you can see on the PET scan, it's quite an enormous tumor, 8 centimeters long. There was no evidence of metastatic disease on the PET scan, but because of the size of the tumor and the involvement of the upper stomach, I did a diagnostic laparoscopy, which showed he had peritoneal carcinomatosis with low volume disease, but biopsy-proven peritoneal disease. We switched from a curative to a palliative treatment paradigm, and he was started on FOLFOX and nivolumab. He had 6 months of chemotherapy and immunotherapy, and then a further 3 months of immunotherapy. And his subsequent PET scan in 2021 showed that he didn't have any metabolic activity. His oncologist referred him back to me for consideration of surgery because of the metabolic response. And then we re-laparoscoped, the peritoneal disease had disappeared, and he underwent an esophagectomy 4 years ago and had the pathology showed that there were some fibrous areas where the tumor was, but he had a complete pathological response, and he remains disease-free at 4 years. And we've had about 12 or 13 patients over the last 4 or 5 years who have had metastatic esophageal and gastric cancer who have been cured after having induction with FOLFOX nivo and then surgery with no recurrences. So the patients who have selected out using FOLFOX nivo, when they had a good response, none of them have had recurrence after surgery. How did this start in Australia? And this will be my last slide. We started doing genetic analysis on pancreas cancers as a group. We got a grant for $150 million, and we proved the concept that you could analyze the genetics, the whole genetic sequencing of the tumor, and then you could tailor treatment for pancreas cancer. Once we proved the concept, the government supported another study called the MoPH study, which expanded the indications to include all solid organ tumors. And again, once we proved the concept in the other solid organ tumors that we could have tailored treatment, they then subsequently expanded it. And now the government funds whole genome analysis of all patients who have cancer as long as you request it. We don't do it for all patients. Clinicians have to request the genetic analysis, which we do in most patients. Those patients, the OMICO, which is our organization which does the genetic analysis, that immediately links patients to phase 1 and phase 2 trials if they have particular actionable mutations, and the patients are given information on the trials and then referral to the particular trial centers. The other activities that are going on in Australia, particularly, we're increasingly using AI for diagnosis and prognosis. It's all under study. AI is used for tumor analysis and for analyzing the genetic sequences of tumors. And it's also we're using the responses to treatment and putting people into non-surgical observation arms when they've had a complete pathological response and they've had a complete metabolic response with their cancers. So in summary, we need to work together. We need to try and implement these types of treatments into every country because ultimately they're going to reduce morbidity and mortality from cancer. Thanks.
Thank you, Dr. Sandrusi. Thank you very much for this very interesting and insightful presentation. And you are able to clearly cover the full spectrum of the topic, from understanding cancer development to introducing the promise of personalized medicine. You also successfully emphasized on the most important approach in modern oncology, tailoring treatment based on the genetic and molecular profile of each patient. Your presentation not only highlighted the complexity of cancer, but also offered hope through innovation, precision, and patient care center. Thank you once again. And now I would also like to reiterate for all the attendees who are with us and interested to ask any questions, please put your questions in the chat box and you'll review them and share them later on at the end of the session. And now we will go on with Dr. Arafat Tfaili to talk about the updates on cancer therapy with the perspectives on Lebanon's context. I also have the pleasure to introduce Dr. Arafat Tfaili, who completed his medical degree at the American University of Beirut, followed by an internal medicine residency at SUNY Stony Brook and Hematology Oncology Fellowship at Georgetown University. He has been a core faculty member at AUB since 2009 and is currently Professor of Clinical Medicine and Head of the Hematology Oncology Division. Most recently, he has been a senior advisor to the Lebanese Minister of Public Health, playing a key role in establishing multiple programs to improve access to cancer treatments and helping to navigate the current economic crisis. Dr. Tfaili is highly regarded as a dedicated physician, educator, and compassionate individual. And in recognition, he has been inducted into multiple honor societies and received several accolades, including the Salim al-Husn Humanism and Professionalism Award. The floor is yours, Dr. Twaili.
Thank you, Christelle, for the nice introduction. And I'd like to thank Dr. Sharbil also for introducing the topic because it relates very well to my presentation. So as you saw from the previous presentation, that personalized therapy is becoming essentially standard of care in most of our tumors, and going blindly with with traditional chemotherapy is essentially old news, and we have to tailor therapy to every patient. And as mentioned also by the previous speaker, unfortunately, this comes at a cost. And cost is very prohibitive. In fact, there's a lot of emerging data, and we saw to one of the slides that access is very different between high-income countries and low-income countries. And this unfortunately has affected us a lot in Lebanon, specifically in the past 4 to 5 years. And prior to 2019, in fact, we were doing quite well. We had good access to targeted therapies, to immunotherapies, and so on. And all the events that happened in Lebanon in the past 4 or 5 years have had a major impact on access to therapy. And this will be essentially the outline of my presentation. Essentially, I'll share with you what happened over the past 4 to 5 years and how it affected access to care, specifically in cancer, the corrective measures that were done, and a few slides about the Lebanese National Cancer Plan and recommendations for the future. So as you know, I guess most of you are in Lebanon. So we have had several events in the country since 2020. So in late 2019, we started to see signs of economic collapse. And then in 2020, the COVID-19 pandemic hit Lebanon among all other countries. And in August 2020, we had the Beirut port blast. And then by summer 2021, almost a year later, we started to see the devaluation of the Lebanese pound, and it lost significant value. And this led to really significant shortage in the budget, in the Lebanese government budget, whether related to health or any other issues. Historically, cancer medications were being provided at a subsidized rate to all Lebanese and even to non-Lebanese before 2019. But by 2021, when we started to have the economic collapse, the Lebanese central bank started to progressively remove subsidies on multiple items, including cancer medications. And I think the major difficulty at that time was the unpredictability. So we did not have a specific budget. Things were changing month by month. You had to make really a lot of decisions that they were not based on science. You have to adjust on a month-to-month basis. And the most unpredictable things was the amount of money you can get to cover these cancer medications. It was only a one-time decision by the central bank. 1 month you get it, the other months you don't get it. So there was a lot of uncertainties. So really it was clear from the beginning that we cannot continue with the same level of care that we had prior to 2019. So we had essentially 3 options. We're talking now September, October 2021. This is when the new government was formed. At that point, I was asked by the Lebanese Minister of Health, Dr. Firas Albert, to be his senior advisor when it comes to cancer. And we had to make some decisions about access to care. So the first option was to insist on having the same level of coverage with full subsidy. It was obvious, no, that we cannot afford this. The second option, this is what was recommended by WHO, the World Health Organization, is that just go to the basic coverage, what's called essential medication list, cover only the very simple medications, cisplatin, 5-FU, and so on. Don't bother with targeted agents, don't bother with immunotherapy. You cannot afford it. And this was not an option for us, to be honest, because we in Lebanon, we pride ourselves with providing high level of care to our cancer patients. We have a very well established health delivery system. So it was not hard, it was not easy for us to swallow that. So we decided to go with a third option, essentially try to weather the storm, try to see what we can afford, what we can do on a month-by-month basis, try to better allocate our resources in order to make sure whatever money we have to make the most use of it. So really a lot of corrective measures were done and in a very fast way. And we're talking only within a few months to meet this challenge. So the first thing is, we started in October 2021. The first thing, there was a visit from the Minister of Health to Central Bank to agree on a specific monthly payment to cover medications, because it was haphazard before that. And that agreement was reached. We essentially, we were allowed to have essentially $25 million a month to cover cancer medications. So based on that, we started to figure out ways how to best distribute this money and how to best make the most of it. Okay. Second, what we did is, so the subsidy in Lebanon was not only to cover cancer medication, it was to cover almost all other medications, including Panadol and everything else. So what we decided is to remove subsidy on most non-cancer medications, anti-hypertension medications, diabetes medications, cholesterol medications, because these are relatively cheap medications. So most Lebanese people could afford paying these. So we removed subsidy on these medications. But at the same time, we made these medications available in the government-sponsored primary healthcare clinics. There are almost 500 primary healthcare clinics in the country, Mustawsafat essentially, and these provide these medications for free. So any of the Lebanese people who cannot afford these medications from regular pharmacies could go to these primary healthcare clinics and get them for free. So this essentially really added a few $1 million per month to our budget. And from there, we wanted to implement lots of systems to optimize the use of this money that we have. To our surprise, the first medications to disappear from the Lebanese market was not the expensive cancer medications. It was the cheapest cancer medications. And because the reason for that was, if I'm an agent who brings a cancer medication that costs $4 or $5, and then I have to get the approval of the Ministry of Health and then the approval of the central bank, and then maybe a year later get paid for my money, the decision was, no, I'm not going to bother and bring that medication. So whatever agents who were bringing these medications said, we're not going to bring our medication. We're going to use our money in construction. We're going to use it somewhere else. So the cheapest medication, in fact, was the first to disappear. So the response was, let's just remove subsidies on the very cheap medications that are less than $10. Almost all Lebanese people could afford these. So we removed also subsidies on these. So this will allow direct import of these medications, and these rapidly became available to the patients. When it comes to the more expensive medications, really we had to put a lot of measures to guarantee the process of access to these medications is very well organized. So the first intervention was introducing something called the United Health Identification Number, UHID. Essentially, it's a serial number that each cancer patient gets assigned at the time of diagnosis. And this number had several purposes. First, to make sure the patient exists and is alive. You might be surprised, how can we have, why do we need to make sure the patient exists? Yes, there were, prior to this, there were some requests at the Ministry of Health for subsidized medications for non-existent patients or patients who already died and so on. So there was a lot of foul playing in the system. So that UHID, take a live photo of the patient, have a copy of the ID of that patient to make sure it's an actual patient with a pathology report, it's with the accurate diagnosis. The second purpose of that number, to differentiate Lebanese from non-Lebanese patients, because at that time, as you know, we have around 200,000 Palestinian refugees in the country, and almost 1.5 to 2 million Syrian refugees. And So the Palestinians were receiving help by the UNRWA, and the Syrians were receiving help by UNHCR. So they had their own coverage system. So it made sense to distribute our money only to the Lebanese people, because the other citizenships, they had their own coverage system. And also, we used to have a lot of Iraqi patients coming for healthcare in Lebanon. There's no need to provide subsidized medications for the Iraqi patients. They could easily afford the non-subsidized medication. So this was another purpose of the UHID. And the last, and I think very important, it will be a source to feed our National Cancer Registry. So any patients diagnosed with cancer, they get a UHID. That UHID automatically appears in the National Cancer Registry. So this will automatically generate data to fill our cancer registry. The next item, the next intervention that was done is a measure of healthcare delivery system. So as you know, in the country, we have a complex healthcare system. There is patients who have a private insurance, patients who have ضمان الاجتماعي, National Security Service Fund, the تعونيت وموظفين الدولي, the co-op, and there are the military insurance, and a good chunk of patients who don't have insurance. So historically, the Ministry of Health took care of covering the patients who don't have insurance. The NSSF were their own, co-op was on their own, and of course the private insurance. And unfortunately, each one of them used to talk to pharmaceutical companies on their own. I want to buy this much drug from you. What price can you give me? So what happened is we merged essentially the uninsured and NSSF and co-op, which essentially contributes almost 70% of the Lebanese population. We become unified as a one voice, that when we negotiate about prices, about quantities with the pharmaceutical companies, we become essentially as one entity. The next intervention was called a Meditrack system. And this was a very important system. Prior to this, in fact, a large portion of the medications that are subsidized by the ministry and get distributed to patients, they get somewhat diverged, and they get sold in the black market at the non-subsidized rate. So the government brings the medication, pays for it, and we're willing to provide a very cheap price. Somehow it gets diverted from the governmental system and gets sold in the black market at a non-subsidized rate. And we're talking millions and millions of dollars. We're not talking a small amount. So the Meditrack system is essentially a tracking system for every vial of medication that enters the country. So at the airport, before the medication leaves the airport, every vial gets assigned a number through its barcode, and that number is followed from the airport to the agent, to the hospital, to the patient. So when the patients are approved with the medication, we make sure through that Meditrack system that it made it to patient X and not to patient Y. It's a very, so you link the Meditrack with the UHID, we know which patient, which file went to every patient, and so on. So this essentially cut significantly the leak in that system and selling the medications in the black market. The next intervention is called the AMAN review process. So it's essentially a committee of oncologists at the ministry, where that committee is essentially charged of reviewing the appropriateness of an indication. So an oncologist wants to prescribe an expensive medication for the patient, but to make sure it's an appropriate indication, it has FDA approval and so on. And it's a completely electronic system. So the oncologist uploads the documents, the pathology, the report, and whatever medication they want on that electronic system. The committee reviews, and all the replies get within 1 week. So this is a purely scientific way of assessing the appropriateness of the prescription habits of the physician. And the next item is also, it was done for the first time, writing restricted national cancer guidelines. Cancer guidelines is essentially guidelines that tell you, let's say for lung cancer, it's appropriate to use medication A, B, or C, and D. But historically, we had some guidelines written in 2013 and 2018. These guidelines did not take cost into consideration. And it was clear that we can continue with these guidelines because simply we cannot afford. Historically, the budget for the Ministry of Health was almost close to 100 million a month. It went down to 25 million. So it was a huge hit. So we had to restrict and include cost as part of the guidelines. So really, we formed a committee of oncologists, and we wanted to make sure whatever we include has a proper pharmacoeconomic value. So we attempted, there's something called LESPOR, that's Lebanese Society for Research Outcomes, where they essentially can give you a very scientific evaluation whether that medication is worth including in your guideline or not. The main limitation was for them to give you this answer, they need at least 6 months for every indication for every medication. So which is a very long process, and we did not have the luxury of time. So really, we had to base these guidelines based on expert opinion rather than pure, very scientific evidence. And of course,
Just Dr. Arafat.
yes.
Yes, sorry for interrupting you, but just to let you know that you have around 10 minutes.
Okay, great. I should be done with
Thank
that.
you.
And with the merger of all of these healthcare system, co-op and NSSF and the ministry, we were able to run a tender, essentially a munaqasa, to buy the drugs as much cheaper. In fact, we were able to save 40% of the cost of the same amount of medications by going together. And the last, and I think is the most significant, is the launch of the National Cancer Plan. It's a full comprehensive 5-year plan from 2023 to 2028 that looks at all aspects of cancer care in the country. And essentially, it's a 6-chapter plan. The first chapter is about National Cancer Registry and surveillance for cancer risk factors. The chapter 2 is about prevention, early detection, all the awareness campaigns, and so on. Chapter 3 has to do with diagnostics and treatment. We need to optimize our imaging. We need to optimize our laboratory assessment and make sure access to our medications and so on. Chapter 4, mostly supportive care, palliative care. It was very underserved and underrepresented in the country. So this chapter was to promote palliative care in the country. Chapter 5 is essentially survivorship. So the cancer survivors, they face a lot of future issues in terms of employability, in terms of ability to get insurance and so on. And chapter 6 is governance, is essentially finding a legal structure to cover this plan in order to be for it to be legally applicable. And this plan, we had a year by year what things we wanted to do, and the plan was essentially launched July 6, 2023. So now next week we're going to be celebrating our 2-year anniversary of the plan, and with a proper look at what has been done in the past 2 years. An advisory committee was formed from all potential specialists who can advise on that committee. This was the first meeting, and it was in October 2023, so it was breast cancer. So the Ministry of Health was lit in pink as a symbolic, but that was the first meeting of the advisory committee. And then we selected, I'm not gonna get because of short of time, but we selected several issues that we can easily adjust. For example, updating the National Cancer Registry, working on a lot of awareness issues, smoking, alcohol, obesity. In fact, the LeMSIC were very active with us in pushing a school smoking awareness campaign for all the 7th graders in the country, and so on. And we collected all the NGOs who are active in the cancer awareness and prevention as one group to coordinate all of our efforts. We had a collaboration with the Ministry of Higher Education. That's in the center is the Ministry of Higher Education in the previous government. So that was February 2024. This was for launching the school awareness campaign. And really, a lot of things are going on right now. as far as awareness and so on. We are in the final stages of getting the HPV vaccine. HPV vaccine is currently available in one form that's very expensive. Nobody can afford it. Very few people can afford it. So we're talking with UNICEF before December. In fact, this morning I heard it. Before December, the HPV available will be to all kids below 12 years and so on. And so really all of these measures have allowed us to weather that storm. In fact, access has been very consistent over the past 12 months. Last March, 2 months ago, we expanded the guidelines. We had excess money that we were able to expand the guidelines. And in fact, next week, there will be another expansion because we're able to follow all of this very strict system of distribution and very close monitoring. So thank you, and I'd be happy to take any questions that you have.
Thank you very much, Dr. Rutfaidi, and for this informative and thought-provoking presentations. You successfully highlighted the crucial elements shaping the future of cancer care in Lebanon, ranging from national cancer data integration and policy efforts to collaborative initiatives, which I find really interesting. And you're also able to emphasize on the most important approach in our local fight against cancer, the development of a structured, accessible, and patient-centered national cancer strategy. We truly appreciate your efforts in making complex public health priorities clear and actionable. Thank you once again.
Thank you.
And now I would like to tell to all the attendees, if you have any question, please, you can put it in the chat box and we will see them and you are going to discuss them at the end of the session. So now also we are going to share with you our second poll survey. So if you can also take a moment to fill it. And in the meantime, we are also going to start with your questions. Okay, so we have our first question from Zeno, who is asking, is the National Cancer Plan available for reading?
It is. It is available on the Ministry of Health website, and I don't know. Maybe I can email it to you, Kristen. Sometimes there's a QR code that you can easily scan it, and I might be able to share the QR code now during this. So once you scan that QR code, the full plan is available. Yes.
If you want, doctor, you can share it with us, and we can share it also with the attendees.
Sure.
Yes, we can attach it in the caption of the YouTube video that will be uploaded, the recording.
Okay.
Okay, and I also personally have one question, which is, given the genetic and the molecular complexity of cancer, what infrastructure is needed in Lebanon to implement personalized medicine on a larger scale?
Is that for me or Dr. Shabri?
Well, I think to start, I'll answer. I think to start, what I would suggest is that you leverage your external helpers. So you pick a disease where it's most useful, and then you leverage the NGOs from outside to provide, and the people who do the genetic testing to provide the tests to start with. And then once you prove the concept in the country, then you can lobby the government to pay for it, or the NGOs to pay for an ongoing facility, but it costs a huge amount of money. We don't routinely do it for every patient, but the ones that we do it for, we have a government-funded program and then a non-government funded program if the patients want their results really quickly. And the testing for the non-government funded patients costs about $1,500 per patient per specimen. So so you have to start. I would start by having pick one tumor and prove the concept in the country, and then you can try and get some increased infrastructure. You have to have centralized biobanking. You have to have all of the scientists that do all the genetic sequencing. And it does cost huge amounts of money, like it's hundreds and hundreds of millions of dollars. And you got to look at whether the utility for that money is better. Like if you look at this, there are other aspects of cancer care in Lebanon, for instance, which may, for the same amount of money, may get a much greater outcome. So you've got to look at the utility of where your money's spent before you go and put, hundreds of millions of dollars into genetic testing and genetic sequencing for tailored treatment.
I do agree with you, Dr. Charbel, because unfortunately, as you mentioned, it's quite expensive and it's not covered in Lebanon. It's not covered. Even insurance companies do not pay for it. So it's usually self-pay, which is the average. It's between $2,000 and $3,000 for every panel. That's a test. So before any of my patients, they in fact, if you go to any oncologist, tell you do the genetic testing, but really, I advise my patients that, first of all, I tell them it's not a guarantee it's going to give you additional options. There's a chance there could be mutations that we don't target. There's a chance there could be a targetable mutation, but we don't have the drug, or it's available, it's too expensive. So they need to know all of this before they go that route. And many times they spend all of this money and they get. The most frustrating is there is a medication they don't have access to. So they need to be aware about all the limitations before they go into this process.
Yeah, I think I would say on average, 80% of them don't have targetable mutations for solid organ upper GI tumors, 80–90% of them. So you're throwing money away for most patients in that situation.
Thank you very much. And I also believe we have Nuhat Haidar. She is raising her hand. So Nuhat, if you have a question.
Yes, hello, doctors. I do have a question for Dr. Arafat. So considering the combined impact of economic collapses like war, pandemic, and the list goes on, which of the proposed corrective measures do you foresee making the biggest long-term difference for cancer therapy in Lebanon? Like the one who would do the most impact?
The interventions that are already done, you mean, or when you're talking about therapeutics, which so let me tell you how we thought about it when you wrote the guidelines. I was the chair of that committee, and we, of course, we look at what's called the hazard ratio, how much the benefit there is from that medication. But the other factors we take into consideration, is this a palliative or a curative intervention? So if we have an indication in the adjuvant curative setting, we give it priority over the metastatic setting. The number two is the duration. If you have a specific duration of treatment rather than open-ended duration, because this way you can definitely estimate the cost and know how many patients you're going to have. And the number three is the total number of patients to be exposed. Also, this will all affect your budget. So all of these factors were taken into consideration. So targeted therapies and precision medicine and gene-specific therapies are really very nice ideas, but almost none of them is curative. Really, almost none of them. The tumors are so flexible. You block EGFR, they get secondary EGFR mutations, they get MET mutations, they transform from non-small to small cell lung cancer. You block the pathway, they have a third pathway. So in targeted therapy, we really rarely see a curative agent. It's usually a prolongation of disease. While immunotherapy, it works in a small population of the patients, but just like in the case that Dr. Charbel showed, you can have a cure from these. Somebody with this advanced esophageal cancer that did not undergo surgery, and when they went for surgery, there was no residual tumor. These are cured. These are metastatic cancer patients who are cured. So I'm more excited about immunotherapy, to be honest, than the targeted therapies. But the problem with immunotherapy, it works only for a small push. We're talking 20 to 25% of the patients. The majority, no, it doesn't help them.
Thank you so much, doctor, for your answer.
I believe we also have two questions in the chat box. The first one is for Dr. Arafat from Fatima. What type of rehabilitation is included?
So when you mean rehab, maybe you mean the survivorship, meaning once they get the care for the cancer, this remains very rudimentary in Lebanon. In fact, this is the main purpose of Chapter 5 of Cancer Plan. In fact, when we did the 1 year evaluation of the National Cancer Plan, we brought two cancer survivors, one pediatric and one adult, and raised these specific issues, the issues that are facing the children who have developmental growth, who have a lot of endocrine problems. She was a young in her 20s, but now she's in her 30s, unable to get employed because she had cancer 7 years ago. And she's not able to get insurance because the insurance companies, when they see the word cancer, they deny. So all of these issues are being addressed with the National Cancer Plan. There's something called, for example, in France, there's something called the right to forget. So once you have your cancer more than 5 years, it's your right to eliminate it from your record. It's not like a crime that you had a cancer 5 years ago. So you should have equal access to insurance, equal access to employment. Even so, the banks do not open bank accounts for these people. So there are a lot of issues that to be addressed in this plan.
Thank you very much, Dr. Arafat. And you also have a second question from Mario. Recently, CRISPR has been used to change the DNA of a living human baby successfully. Could this be used to help prevent cancer in those with a genetic basis that is at higher risk of cancer?
Hopefully. In fact, there is the first application of that was in hemophilia. So this was just got a few months ago. So the factor 8, they were able to modify factor 8 to produce the normal factor 8 rather than the defective factor 8. So the first human application is already there in hemophilia. In cancer, it's still a long way. As you saw from the presentation of Dr. Shelber also, most of the time in cancer is not a single mutation, it's a multi-hit process. It's not something, our body is very resilient. You have one mutation, your body takes care of it or eliminates that cells completely to avoid it behaving abnormally. But when you end up with cancer, it's usually multiple mutations that already hit that cell that are very hard to reverse. So I think the applications remains very limited unless you mentioned something genetic, BRCA1, BRCA2, to prevent cancer in the future. Yes, that's something very reasonable to think about, but the technology remains really far behind. We're not there yet. The first application was in hemophilia, and there was a successful application of that.
Thank you, Dr. Arafat, and thank you, Sherber. Do you have an input about that?
Yeah, we have like I think there are active trials going on for ATM and for some of the other like simple genetic mutations which predispose patients to cancer. They're actively sort of in process of studying that. So yes, that will be part of treatment. They may also use CRISPR to try and improve the response to chemotherapy or to immunotherapy, like to try and induce some genetic change that improves your treatment response. But that's a while away. There's a lot more low-hanging fruit to get sorted out before you get to genetic modification of human beings for treatment of cancer.
Thank you, Dr. Sherber, also for your input. And if anyone has any additional question, please feel free to put it in the chat box. And I would also like to remind you to take a moment to fill the poll survey too, if you haven't yet. And if we have no more questions, I would like first to thank you both, Dr. Twaidi and Dr. Sandrusi, for your insightful and complimentary presentations. you are able to shed light on both the systematic and individualized approaches needed to transform cancer care. Dr. Twining thought through the lens of national strategy, policy, and accessibility, and Dr. Sandrusi through the promise of personalized, targeted treatment. Together, your talks offer the holistic and forward-looking vision for improving outcomes and equity in cancer management. Thank you again for sharing your expertise. And I believe also as a closing remarks, I thank you all for joining us today for this vital discussion on advancing cancer treatment. We had the opportunity to explore several aspects on cancer, whether about personalized medicine or also in the context of Lebanon. And thanks to your clinicians, healthcare workers, who I send them our regards, private and public sectors and NGO supporter groups to ensure no cancer patient is left behind. I would also like to extend my gratitude to both doctors, Dr. Twining for sharing valuable updates on cancer therapy in Lebanon, and also a special thank you as well for Dr. Sandrusi, not only for his insightful presentation on advanced cancer therapies, but also I believe for staying with us despite the late hours. So I believe if now it is 8:25 in Lebanon, it should be around 3:25 a.m. in Australia, if I'm not wrong. So thank you very much.
It's time to go for work for him.
Okay, yeah, no worries at all, doctor.
Just about another 2 hours.
And as we move forward, let us stay committed to transforming scientific progress into equitable care through advocacy, innovation, compassion, and research. Together, we can strive toward a future where every patient receives timely, effective, and affordable treatment, a goal we continue to pursue in Lebanon and also abroad. Once again, I thank you on behalf of everyone for your participation, your insights, and your continued dedication to improving the lives of those affected by cancer. Have a joyful evening. Thank you, everyone. And also don't forget you can have access to the webinar later on the YouTube channel of the Ministry of Public Health. And thank you.
Thank you.